Thank you for the generous introduction, Tony. Somebody described me the other day as a value-based healthcare crusader, and I felt like I needed a cape to go along with that. So maybe next time if we're presenting together, Sally, we need one of those. So I just start with a bit of an introduction about oral health in Australia. The focus of this talk is going to be about Dental Health Services Victoria and our work in value-based healthcare. So oral disorders, including tooth decay, gum disease, and severe tooth loss, are the sixth biggest source of non-fatal burden of disease, ranked above cancer, gastrointestinal problems and injuries. Oral diseases can contribute to other health problems, including diabetes, heart disease, and Alzheimer's. The impact of oral disease on people's everyday lives is subtle, pervasive, and includes influencing eating, sleeping, rest, and social activities. Tooth decay is 5 times more common than asthma in children. An estimated 67,000 potentially preventable hospital admissions are due to dental conditions, which represents 21.5% of all potentially preventable admissions for acute conditions in the public sector. And more than 2 million Australians report that they avoided or delayed going to the dentist despite needing care at least once in the past 12 months due to the cost. Next slide, thanks. In Victoria, the structure of public oral health service is complex. There are multiple providers, funding bodies, and governance structures which tend to operate in silos. The current model of funding of the public dental services in Victoria is focused on treatment and is demonstrably less cost-effective than a preventative approach. As a result, performance is measured by output. Hence, there is no clear indication if the dental service is actually meeting its objective to improve health outcomes and address the existing health inequalities in Victoria. Clinicians do not have an opportunity to work to their full scope of practice. But this is actually changing as we adopt and move towards a value-based model for oral health care. So what does it mean to provide value-based healthcare in oral health? We've heard certainly Sally give us a fantastic and very eloquent description of value-based healthcare and what it means in Wales and could mean for us as a system. But it means for us at Dental Health Services about improving health outcomes that matter to patients with minimal waste of time and resources. As healthcare providers, one of our problems is that we're not very good at measuring outcomes, the numerator, particularly from the consumer's perspective. We can measure activity and some clinical safety indicators, or what I call the absence of negative outcomes, but the presence of positive health outcomes is harder. And as you can see from the value equation, this prioritises the health outcomes that matters to patients. So to achieve this, we need to develop a set of outcome indicators and commence measuring them, and I'll talk to that in more detail later. Then there is the issue of cost. And this, as Sally said, this is actually not about cutting costs or saving money, but it's to reach a budgetary bottom line. It's about determining the most efficient way to deliver a good health outcome and then carefully considering who is best to do that. There are many components to consider with cost, of course, in the delivery of healthcare, but we know labour is a serious component in that total. And at the heart of all of this is actually empowering clinical leadership so that the data is provided in a meaningful way to empower clinicians to deliver the best health outcomes. So looking further into the value agenda for dental health services, we want to achieve the best health outcomes at the lowest possible cost. Again, not about cutting costs, but enabling reinvestment of resources into more and better care. We want a system that is person-centred and co-designed with consumers. We need the right services being provided by the right person in the right location. And we also need to integrate care and get rid of treating a single illness within a silo. I think we've demonstrated many times that's not very effective. We need to know what good health outcomes look like and know how to measure them effectively. And we need to reduce variation of care across geography. So our journey. We started the journey to improve health outcomes in the public oral health sector around 7 years ago with a model of care. When I joined the board, we undertook a new strategic plan. with a strong focus on the life course of the tooth and the person and looking at prevention. Soon after this, I worked with the CEO and the board to determine how we could use value-based healthcare principles to deliver our strategy. We took the Harvard model and adapted it to suit the unique circumstances of the oral health sector. And in fact, I remember talking to someone from Harvard about how to do this in oral health, and they said, we have no idea, just start somewhere. So we did. In Victoria, we do have an advantage in the oral health environment, and then some of that mirrors some of the elements of Wales, I think. The public sector has oversight of the majority of the oral health care pipeline, so it's a great opportunity to integrate prevention and clinical intervention into the model. So the model that we developed has 10 core elements with consumer and workforce engagement and co-design at the centre and the heart of it. Through this model, we've been using the value-based approach to transform oral health care. And to do this, we've had to undergo many major procedural and cultural changes, and we're still undergoing those. Each of these wedges represents a huge body of work within the organisation. Next slide, thanks. So what should the future of public oral health look like? To determine what the future should look like, we adopted the nothing about me without me concept and actively engaged with our consumers and workforce. We asked our consumers to share their lived experiences when accessing oral health and what do they value and not value when they're accessing the services. And we asked what are the challenges of working in the public dental system and how can we overcome them from our clinicians. Next slide, thanks. This is what our consumers told us. Before they arrive, consumers want to be well informed and understand their journey. When they arrive, they want to know what to expect and where to go. They want to receive care that is respectful of their culture and language and be engaged in decisions by having control, empathy, and they want to be heard. After they leave, consumers want to continue to be engaged, empowered, and informed. This is what our workforce told us. They want to be able to make a difference to health outcomes. They want consumers to arrive prepared and ready for care, to have all the information needed to complete what care is required, to be empowered to work at the highest level of their scope of practice, to better support each other and consumers in a team environment, to have systems and equipment that support them to provide the best care. Which sounds simple, but we all know so often those systems in healthcare don't provide that sort of support. To be able to use their health knowledge to improve systems and health outcomes and to be able to measure and monitor outcomes that actually make a difference to patients. Next slide, thanks. So I'd now like to move on to the model we developed and how co-designed with consumers and the workforce. So as you can see, and as I've already mentioned, co-design is at the centre of the model we developed. Our approach to co-design is not the old approach to co-design, where a group of people develop a process and then ask consumers and clinicians if they like it. We actually, since the start of value-based healthcare journey, genuinely involved our staff and consumers right from the beginning. We listen to them and they have been partners with us every step of the way, from discussing to planning to testing and even evaluating, right down to the very words we use. Our new value-based models of care comprise two core components, which you can see highlighted in the diagram: individual interventions and population and setting-based interventions. As you can see, designing the client journey is the first point in individual interventions, along with prioritising care based on risk and need, and measuring then evaluating outcomes so we can continuously improve both the individual's outcomes and the services we provide. We recognise, for us, that this is uncharted territory and we won't always get it right on the first attempt, but we're very much taking a learning approach to this. Our population and setting-based interventions focus on using evidence to inform all of our preventative interventions, developing interventions for each stage of our consumers' lives, and evaluating all the interventions to ensure that they are improving health outcomes at the most efficient cost. Next slide, thanks. So to improve health outcomes, you must have a proven and robust way of measuring them, as we've heard Sally talk to today as well. So we've never been particularly good at measuring outcomes, as I mentioned, particularly from the patient or the consumer's perspective. We can measure activity and, as I said, some clinical safety indicators, but I'm not sure that many patients turn up thinking that a good outcome is they don't get an infection. I think they actually have some really positive health outcomes in mind, and that's where we're really struggling, I think, at this point in time to measure those. So we needed to develop a set of outcome indicators and then start measuring them. So DHSV partnered with two of our incredibly dedicated consumer representatives who were on telcos all the time of the day and night to work with the International Consortium of Health Outcome Measurement, or ICHOM, although I wanted to put a P at the end for this work and call it ICHOMP, to develop a standard set of oral health outcome measures for adults and children. Asking the questions from the standard set of oral health outcome measures have been embedded into our new model, and we ask these questions at planned periods during the consumer's course of care so we can actually see if they're improving in their outcomes. Next slide, thanks. So here is an example of how we're implementing health outcomes. In October 2018, we commenced a proof of concept, which has been operating for a year now. The proof of concept was used to test our tools and processes. The changes to the model of care include the introduction of group sessions. At the group sessions, consumers receive oral health care information and information about our new way of working, so the prevention messaging happens up front. We emphasise that this will be a partnership model with clinicians and consumers. Instead of having a first-in, best-dressed approach being placed on waiting lists, consumers receive an appointment based on self-reported oral health risk and need, and this is determined by their responses to the ICHOM questions. Care is delivered by a multidisciplinary team that are working to the top of their scope of practice. We're asking our consumers to tell us what their oral health goals are, and our clinicians are co-designing care plans with them to achieve these goals. Through oral health coaching sessions, consumers are receiving information that's tailored to their oral health needs and know what they need to do to achieve their oral health goals. And we have a planned approach to follow up on their progress. So are we achieving good outcomes? In this new model, our patients are definitely more engaged. 9.6% of patients failed to attend a clinical appointment, and this is in comparison to 18.4% of patients in the traditional primary care oral health model. And 97% of the group session attendees found that the information was delivered was useful. Our workforce is also more engaged. They tell us what information, processes and systems they need to improve their practices. They openly discuss topics such as variation in a non-blame environment, and they ask for measures to evaluate and improve their own practice. The information that's actually on this slide was collected from the same patient using the ICHOM questions over the course of approximately 3 months. During this time, the patient received mostly preventative treatments, such as oral health coaching sessions. Originally, the patient reported that they had very poor mouth, teeth and gum health, and they were embarrassed about their mouth to the extent that their daily social interactions and life functions were being inhibited. Now the patient reports their oral health as being good, and there is an increase in confidence about their appearance and for the mouth and teeth. Notably, and I think this is a really important point, there's also a behavioural change. The patient now reports that they only consume sugary food and drink a few times a month compared to daily prior to these interventions, which not only obviously improves their oral health, but will have significant knock-on broader health impacts. We're continuing to design and improve our systems and processes, but the key difference now is our workforce is asking, what do our consumers think? Let's test this idea with them before we progress. Next slide, thanks. So I just wanted to share with you another example of embedding a culture of co-design. Last year, the school dental program, the Smile Squad, was relaunched in Victoria, and we ran workshops with children and their parents. They told us they wanted flying dental vans with beanbags, and even though we couldn't actually add wings to the vans and we couldn't replace the dental chairs with beanbags, we did actually take on and use the suggestions and ideas that they gave us, and it's informed the vision and the end result. So as a consequence, the consumers, the children, parents actually feel engaged with the program. Next slide, thank you. However, it's important to acknowledge that change of this scale is challenging and can be unsettling for the organisation. You need all members of the workforce to be engaged. We developed a respectful workplace framework to enable staff to be the best they can be and support them during this time of change. This framework and the value-based healthcare principles has motivated the staff to embrace the change and empower them to actively transform the public oral health services in Victoria and improve health outcomes for all Victorians. Thank you very much.